Go. Emily, I take it you can see that, please? Good.
Yes.
Okay. Thank you very much. All right. I'm going to sit down for this presentation, so that's why you see me a little bit lower on the screen than before. So, in discussing medications, just as when I discuss psychosocial treatment for ADHD children, I like to explain both to families and to other interested adults why are we using medication with ADHD children. Obviously, we do so because it has a very large evidence base for its risk-benefit ratio, for its effectiveness. So that evidence base involves now hundreds, if not thousands, of controlled trials comparing the various medications to placebos over various intervals of time, up to and including about 2 years in terms of controlled randomized trials, and beyond that in terms of following people up in longitudinal studies who have been on medications for years. So the evidence base is quite substantial. Indeed, probably more evidence for the effectiveness of ADHD medications than for any of the other psychiatric medications that are available, that is proving their effectiveness. Of course, what this evidence base has shown is that the medications are incredibly safe, besides being effective. And indeed, I argue that they are the safest medications prescribed in psychiatry, just because of not only the amount of evidence we have, but the evidence showing that most of the side effects, although annoying, and annoying enough in some people to have to be dealt with through various forms of adjustment to the dosing, the type of medication, the delivery system, the timing, but not in terms of being life-threatening or leading to long-term physical or emotional harm to the individual who takes them. So all of the issues that have been raised previously, as we will discuss in this presentation, with regard to long-term safety have been addressed quite nicely now in very large population studies of people taking the medication, as well as longitudinal research like mine that has gone on for 20, and in the case of New York, the 30-year follow-up studies. We're seeing high rates of improvement in individuals with medication. 70 to 90% of clinical cases show a positive response to one or more of the medications on the market. 50 to 60% of those cases are brought to within the typical normal range of behavior with regard to ADHD. So there is no other psychiatric medication that can match those statistics. That's not to say that everybody responds, they don't, right? And we're going to talk about that in this presentation. But the rate of responding is greater than we see for anxiety drugs, antidepressants, certainly with the antipsychotics as well. So, and the degree of normalization is markedly greater than we see, as well as the degree of improvement. So it's not just the number of cases or the percentage of treated people that respond, but the degree of change is 3 times greater, at least, than we see with other psychiatric drugs. So the amount of improvement is quite impressive. Medications compared to psychological and other treatments are very convenient to administer. They're also often cheaper than the other forms of intervention. And we have to keep in mind that while medications have side effects, as I mentioned in my last presentation, so do psychosocial treatments as well. The expense of medication, of course, cost effectiveness has been shown repeatedly to be quite good in terms of its profile. And then medications can be used for years, even into adulthood and across the lifespan, where necessary in reducing harm and reducing impairment and managing the individual's symptoms. So we have a very good window of influence here from young childhood down to age 2, all the way up into the elderly years of using these medications, with some caveats, of course, depending upon other characteristics of the patient we're going to talk about that need to be weighed in terms of medicating and choosing the right medication for the right person, but we'll talk about that. And then, of course, medications can be used and remain active across a diversity of community settings where psychosocial treatments simply can't be implemented for children or teenagers. When a teenager is driving home on a Friday night late in the evening, having been to a party or a dance or something, the medication can be present in the bloodstream, whereas a parent may not be there during these unsupervised times in the community when the child is waiting at the bus stop or out in the community, or in the case of teens, among peers or at the mall or engaged in other unsupervised activities. Medication can be there in the bloodstream. So medications produce a far more pervasive effect across community settings. And then now, as I will go into in a little bit more detail in this program, we have more than 33 published studies showing that the longer you stay on ADHD medication, the more likely the brain is to grow and normalize in the areas of the brain where ADHD arises. And that has been called neuroprotection. The term, I think, is a misnomer. It was borrowed from the literature on the neuroprotection that antidepressants seem to provide for dementia, but it really should be neuroenhancement, because unlike neuroprotection, there is evidence here of neural growth in underdeveloped brain regions from remaining on medication. We'll go back into that later. It seems to occur in about 25 to 40% or more of patients who stay on medication for several years or longer. It remains a somewhat arguable effect among neuroimagers, but as I said, there are 33 studies now that have found people staying on medication show more brain growth than those who don't. We don't know the characteristics of the people likely to improve. Again, I'll come back to these points a little bit later in this presentation. As you see here, at least in the United States, we have 3 different classes of medication that are approved by our Food and Drug Administration for explicit use with ADHD children and adults. Of course, the stimulants have been around the longest: amphetamine since the 1930s, methylphenidate since the 1950s. And of course, we're talking here about the various methylphenidate products that I'll mention when we get into these, the different delivery systems that are available now for them, as well as for amphetamine. And then, of course, here in the US, starting in 2003, we had approval for the non-stimulant, which is a norepinephrine reuptake inhibitor, which is atomoxetine. And there are other drugs in the pipeline that are also probably going to be coming up for approval soon that are norepinephrine reuptake inhibitors as well. And then most recently, starting around 2009 in the United States, were the old antihypertensive drugs used to treat high blood pressure, often called alpha-2 agonists, these being guanfacine and clonidine, that were reformulated into extended release delivery systems for use with people with ADHD, and those have now been approved for use as well. So those are the approved types of medication that we have available, and there are many different names and delivery systems for the drugs in the marketplace within these 3 compounds, or these 3 types of medication. Of course, there are also other medicines used in the US off-label. I'll show you some of them, but I, of course, am not recommending them to you at this point because they don't have our FDA approval. But clinicians are well within their rights to use those medications off-label if they feel they are appropriate. If you're not familiar with how these medications work, quite simply, I'll be very brief here because some people find the neurochemistry of this rather boring. But in the case of the stimulant medications, let me describe the diagram here. Here you're looking at nerve cells that are projecting their boutons, if you will, but their terminal endpoints into a synapse, which is a cleft or a gap between nerve cells. So here's the presynaptic nerve cell. and here's the postsynaptic nerve cells they're projecting onto. This is the gap here. And what we see is that as a signal moves down this nerve cell to its terminals, there are packets of neurotransmitters in the terminal for dopamine and norepinephrine. You see over here, this is a norepinephrine nerve cell. This is a dopamine nerve cell. And as the electrical signal moves into the terminal, these packets move to the membrane. They erupt and express the neurotransmitter into the synapse. That neurotransmitter crosses the synapse and binds to the next nerve cell on its postsynaptic membrane. And if there's enough neurotransmitter that binds to that nerve cell, it will trigger an electrical signal in the postsynaptic nerve. So that's how the nervous system is working. It's a neurochemical electrical system. And in this case, we're interested in the norepinephrine and the dopamine nerve cells. So how are the stimulants working? Methylphenidate primarily works by blocking this little pump known as a reuptake transporter. They're on dopamine nerve cells all over, by the way, not just here, and they're on norepinephrine nerve cells. And their job is, once the chemical has been expressed into the synapse, is to vacuum that back up into the nerve cell after it's done its job. So there are these transporters, these pumps or vacuum cleaners, if you will, all over the endpoint, and they're going to pull the transmitter back in and repackage it. In the case of methylphenidate, it's blocking mainly the dopamine reuptake inhibitor, but it may also work on the norepinephrine reuptake pump as well. Amphetamine is known to work on both of them, not just the dopamine one. And atomoxetine, which is the norepinephrine drug, works primarily and exclusively only on the norepinephrine. But what all the ADHD drugs are doing is preventing reuptake. The end result, there's more of the neurotransmitter left in the synapse to bind to the receptors and fire the nerve cells. So very interesting. That's why all of the ADHD medicines, well, the stimulants and the NE reuptake inhibitors are working by blocking reuptake. Okay, now when we get to the alpha-2 drugs, they are working on the alpha-2 receptor. So here's our nerve cell right here. Okay, there's one, this is a glutamate nerve cell. This is a norepinephrine nerve cell. These mainly are up in the cortex or the frontal lobes, but they're elsewhere as well. And on this receptor nerve cell, besides these little reuptake or these receptors rather, we have these alpha-2 ports right here and here. Now, what happens is when a signal comes into this nerve cell, right, and crosses over and triggers a reaction in this nerve cell, these portals are going to open and close like sphincters, and they are going to determine how strong that signal is moving along that nerve cell. If they're open, the signal is degraded and it won't be as strong moving through the nerve cell. It's going to be more noisy, and it may not even fire the nerve cell all the way up to its own termination. Right? Now, what are the alpha-2 receptors, clonidine and guanfacine, doing? They are closing the portals. What does that do? It creates a stronger signal in the nerve cell that is less degraded by other, if you will, noisy nerve cells around this particular nerve cell. So it's working in a very different mechanism than the stimulants or even than the norepinephrine reuptake inhibitor, which is working here on the norepinephrine pumps. So although all of these drugs reduce ADHD symptoms, they do it through different mechanisms on the nerve cells, and they do it through different regions of the brain as well. And this is just a diagram showing the closed portal and the stronger signal. So that's how the drugs are working in the brain. Now, let's focus on the stimulants. We have methylphenidate and amphetamine. We no longer have pemeline, which was taken off the market several decades ago because of the potential for liver problems, hepatotoxicity. And although it was rare, it was enough to warrant discontinuation of the medicine. But pemeline is still around in other countries, and sometimes is seen even in our countries in off-label generic forms. But we don't use it for ADHD any longer. The real news over the last 20 years has been in several areas. One is that we know that about 75% of people respond to one drug, one delivery system when it's tried. So about 3/4 of the people we try a drug with have a positive response. If you try both stimulants one at a time and their separate delivery systems, you can get up to 90% or higher response rate. So you never judge what the ultimate response rate is going to be from the one drug and delivery system that you may have tried. You may need to switch to another drug or even change delivery systems so that the Concerta osmotic pump does not work the same way that the pellet release SODA systems work, does not work the same way that lisdexamfetamine, which is a prodrug, works, or the new Jornay PM, the delayed release stimulant. They all work somewhat differently in terms of their digestion, absorption, their psychopharmacologic profile, and as a result, people may respond to one better than the other. Try them all in succession, you get a pretty high response rate. So only about 10% or fewer of people do not respond to these drugs. Now, the average time that people stay on medication is about 6 months to 3 years. That's a problem. We're going to have to come back and talk about that because adherence to medication is a big difficulty. People often discontinue for a variety of reasons, despite the profile here of safety, of efficacy, and of duration. So sometimes our problem in practice is getting people to go back on their medication when they've stopped. I'll talk later about the reasons for this and what we might be able to do about it. But nonetheless, people are not staying on these medications lifelong, even though they could take them as long as they need them to reduce impairment. The second thing that's new in the research community over the past 20 years has been the ingenious creativity of pharmaceutical companies at finding ways to sustain the medication in the body for longer intervals of time. So when we look at the original pills, we have medications that lasted only 3 to 4 hours, 5 at most, but usually 3 or 4. And they were being used with children, so they had to be taken 3 times a day. Very annoying, especially at school, created safety problems as well. And you had this roller coaster ride of therapeutic blood levels across the day. Not a very good system. And so the drug companies went to work on creating mechanisms, engineering delivery systems that keep the blood level up as much as possible for long periods of time. Most of them 8 to 10 hours, some of the newer ones 12 to 14. So we now have, despite having, say, 2 drugs, methylphenidate and amphetamine, many different delivery systems getting into the body. So we have what I call the 5 Ps, the pills, the original immediate release medications, the pump, which is the Concerta osmotic Oros technology. I'll show you that in a moment. The pellet system, which is the time release little pellets of medication. We have Daytrana, the skin patch that you wear and absorb the medication through the skin. This is for methylphenidate. We have the latest prodrug, which is the lisdexamfetamine, commercial name is Vyvanse, which is very different from these other delivery systems I'll mention in a moment. And then, of course, we not only have the old immediate release liquid forms of methylphenidate and amphetamine, but now we have liquid versions of the sustained release forms of methylphenidate and amphetamine. And most recently, we now have the gummy bear delivery systems, the chewable, dissolvable on the tongue versions of amphetamine and methylphenidate. And then a year ago, the latest invention is a delayed release, extended release form known as Jornay PM. You take this at night and it activates reliably 9 hours later, so that the child's medication is activating as the child is awakening, and the child is now getting a therapeutic dose during the early morning hours to improve early morning functioning, which we know from multiple studies was a major source of stress in families, even if they were using ADHD medications. This early period of 45 minutes to 90 minutes when the other medications were being given to the child upon awakening, it took that long a time for the drugs to activate, leaving the child essentially untreated and leading to great distress during one of the most distressing times of the day, even for typical families, which is getting your children up and out the door to school while you are preparing to go to work, while you are also getting their siblings, if there are any, ready to leave as well. A very chaotic time with a terminating endpoint that also leads to distress. We have a time period here that we have to get you out the door. So it's interesting that a company chose to develop a delivery system that targets addressing that period of time in the morning, while at the same time, the drug lasting about 10 to 12 hours or more across the day as well. So delayed release, extended release. Yet one more choice in our armamentarium of ADHD medications. If you're not familiar with the Oros pump, this is Concerta. It is a capsule with a laser drilled hole in it, and there are 2 chambers of medication. It's a methylphenidate paste or sludge, and this is an empty chamber here, and there is powdered methylphenidate on the outside. And when this is swallowed, the powder activates immediately, as it did in pill form, and that gives time for water to enter this chamber at a continuous rate. And as it does, it pushes down like a tube of toothpaste, if you will, or more like a plunger in a piston, and it squeezes the methylphenidate sludge out for a period of about 8 to 10 hours, sometimes 12 for some children. The dose of medication coming out initially is a little weaker. The dose of medication coming out later in the day is higher, because children need more medication later in the day than earlier. And that's because ADHD symptoms are worsening, and therefore we need more medication as well. At least that's the explanation for that. So what an ingenious device for getting a medication into and staying in the body as the capsule moves throughout the gut. And this is what happens. I mean, what you're seeing here, here's the blood level for methylphenidate 3 times a day. And that's that roller coaster we talked about. So you're up to therapeutic, now you're subtherapeutic, then you're back up, then you're down, then you're up. And what the Oros delivery system did is to release the medication and keep the blood level relatively continuous, so we don't have this up and down, and we stay in a therapeutic range of blood levels over time. Absolutely ingenious system. Okay, here's your pellet delivery system. This is like your Adderall XR, your Focalin extended release, and so on. And what happens is you have a capsule, you've got all these little pellets, they each have different coatings of medication on them. Each will dissolve at different times of the day. And so as this moves through the gut, these are dissolving at different time periods. And again, looking at the graph, you can see that they keep the blood level relatively even, particularly at midday or at mid dosing, when it would have become subtherapeutic if you were using a tablet form. The interesting thing about this pulse or sawdust delivery system is if the child has difficulty swallowing the capsule, it can be opened and sprinkled on, say, applesauce or yogurt and consumed that way without altering the pharmacologic properties of the medication. This is your matrix transdermal patch under the name Daytrana, worn on the shoulder or buttocks with the medication being absorbed through the skin. Not used as often as I think the company had hoped it might be. About 1 in 6 people gets a skin rash from the methylphenidate and has to stop taking medication this way, but useful for some people who don't want to take oral medications, or for children who can't or won't swallow the tablet or the methylphenidate capsule, for instance. The next delivery system developed was the prodrug, known as lisdexamfetamine. You know it probably as Vyvanse. This is a very different delivery system that the FDA created a new name to describe called a prodrug. And it works like this. You have a amphetamine molecule, in this case, and it is bound up with a lysine chemical so that it can't activate. The lysine locks the amphetamine so that there is no therapeutic action taking place until this chemical is put into an environment where there is an enzyme that can cleave the lysine off. And now the amphetamine can go to work. And that environment happens to be the human gut, and especially the lining of the intestine, which is rich in lysine, or in the enzyme that cleaves the lysine away and is able to convert the drug to amphetamine at a continuous rate as it moves through the gut. So here you see the cleaved components of the chemical. This was developed in hopes of reducing or eliminating the likelihood of amphetamine diversion and abuse, because you can't sniff it, you can't inject it, and get the same degree of effect you would get from oral consumption of the medication, or at least that's the hypothesis here. And so hopefully that reduces the street desirability of diverting this medication. Quite by accident, it was discovered after this was marketed that this is one of the longest acting of the delivery systems on the market, lasting from 12 to as long as 14 hours long. So although it is chemically similar to Adderall, it's an amphetamine, for instance, and it's a sustained release like Adderall XR, the way it's formulated, rather than being a pellet release delivery system, this prodrug delivery system seems to result in a smoother onset with somewhat fewer complaints of side effects, perhaps a longer window of therapeutic efficacy, and a more gradual, softer offset. So in my clinical experience, we are finding that many adults in particular prefer this delivery system to some of the others that come on very quickly, such as might dexedrine or benzedrine or even Adderall. So many delivery systems to choose from and to match to the lifestyle, the schedule, and the other characteristics of our patients. A third development over the last 20 years has been the recognition that stimulants are safe and effective when used with preschoolers. And although there were about 22 or more studies of preschoolers, including several that I did back in the 1980s and 90s, the federal government here in the United States, thanks in large part to being pressured by Hillary Clinton's presidential campaign, believe it or not, set about studying the safety and effectiveness of methylphenidate in a large sample, indeed the largest sample of preschool children entering a drug study. at that time anyway, was the PAT study, Preschool ADHD Treatment Study, a multi-site study involving 303 preschoolers, out of whom eventually 165 would roll over into the medication trial. These children were about 3 to 5.5 years of age. You can see the light, but 3 different doses of methylphenidate that were given 3 times a day to these children. And what was discovered is that A, the medication is effective. B, it's not quite as effective. So that instead of improvement in symptoms called an effect size of being about 0.7 up to 1.0, a slightly smaller effect size of about 0.4 to 0.8. So if you wanted to translate that into fractions, you're probably looking at about a 20 to 30% lower degree of improvement of an individual's symptoms. Also, a smaller percentage of the kids were improved. As I mentioned earlier, on average, about 55 to 60% of people who take a medication like methylphenidate are normalized. Here they found that 22% were normalized. So they improved, many more did, but they weren't brought into the normal range the way school-age children are. So both of these effects suggest that the stimulants are not quite as effective at the preschool age group, but they are safe, they are effective, and they do work to normalize some children, but they're less tolerated. So instead of 3% of children not tolerating the medication after age 5, it climbs to about 8% in the study, simply couldn't take the medication. Side effects were annoying enough to stop it, or about 1 to 2% of children can develop a psychosis, hallucinations. So in that case, they have to stop it immediately. And of course, the symptoms go away. Otherwise, the side effects profile was identical. There were no new side effects not discovered in school-age children. But kids were more likely to have them than school-age children were. And you can see here again, just in school-age children, there is some effect on growth, though it's temporary. There is some effect on failure to gain weight, and some effect on height. But no new side effects. So again, the profile is very similar to what we see in school-age children, just not quite as effective, and perhaps slightly higher incidence of side effects. Overall, the conclusion of the study, the methylphenidate is safe and effective to use with preschool children down to age 3, if necessary, if the child's symptoms are moderate to severe, and you've tried other interventions combined with it, such as behavioral parent training. Now, the effects of stimulants across the board, whether we look at children or adults, are numerous, and they have been documented in hundreds of studies. I'm not going to read these to you. You can read them on your own. I just wanted you to see the lengthy and diverse list of improvements that we see in group studies of patients taking stimulants to control their ADHD. Again, not everybody sees every one of these improvements, but these are what we document in the groups of people that have been studied across the research literature. So it's quite impressive, as we see here, as I move down this slide to show you the documented effects on social relationships, on awareness in sports participation, on reduction of exposure to punishment at home and in school, improved handwriting, improved working memory, improved organization, improved compliance with adult requests, reductions in accidental injuries and in death rates. Improvement in driving, improvement in auto accidents, improvement in suicide. All of this has now been documented in various analyses in the literature. And then, of course, now discovering that these medicines can be used when ADHD is a comorbidity with other disorders such as autism spectrum disorder and with bipolar disorder as well. So lots of improvements in individuals with ADHD from these medications. But again, they don't help everybody, and they don't help everybody to the same degree. And there are side effects that we have to contend with, which can be quite annoying. The 4 most common side effects documented across all of the literature are seen here. 50% rate of insomnia or delayed sleep onset by an average of 20 minutes to an hour. Loss of appetite, usually for the noon meal, affecting about half of the people who take it. Now, in adults, this is really not a side effect. Most adults don't mind having less appetite and therefore losing some weight. But in children, that would be a problem. About 20 to 40% incidence of headache and stomach ache. Most of these will dissipate within 2 to 3 weeks. If they don't dissipate, they can be dealt with through adjustments of the medication, of the dose, of backing up the timing of the medication, of changing to a different delivery system, or moving from a stimulant to one of the non-stimulants. So there are various ways of addressing the side effects. In lesser cases, we do see some other side effects that can be more annoying, a proneness to becoming emotional, sad, crying, to sentimentality, if you will, irritability, especially as the medication is washing out of the body. Less than 10% of children may develop a nervous tic or a worsening of their Tourette syndrome, which is quite rare, but it can happen. When it does, in about a third of the cases with tics or Tourette's that were pre-existing conditions, stopping the medication results in a return back to baseline. So this is not a permanent worsening of the tic reaction. And even in those cases where tics are pre-existing, 2/3 of cases can tolerate the medication with no adverse effect on their tic disorder. So this is why the Tourette Syndrome Foundation and many people who treat Tourette's are now encouraged to use medication where ADHD is present with someone with a tic disorder. There is a well-documented failure to grow. It's not a loss of height or a loss of weight. Children don't get smaller, they just fail to keep pace with the pediatric growth trajectories that would be typical for their age group. We're looking at a failure to gain weight of about 1 to 4 pounds in the first year, or about 1 centimeter of height during the first year. This may last 2 to 3 years, and then we see this dissipate. So there is no evidence of this continuing into adolescence or adulthood. And indeed, by adulthood, the research shows that there has been no adverse impact on adult stature, height, or weight from having been on a stimulant in childhood or adolescence. So these are short-term failures to gain. They're often mild, of no clinical concern unless you're dealing with unusually small children who are having trouble growing anyway, in which case you might want to institute the usual holidays of off medication on weekends and summer months. But in the average ADHD patient, where growth is not going to be as much of a concern, we do not recommend drug holidays anymore, because ADHD can be as bad on weekends and summer holidays as ever. And these are the periods where their life is threatened through accidental injury, through exposure to potential abuse, to possible death, to suicide, not to mention the psychosocial adverse effects of coming off medication, of impaired peer relationships, increasing stress within families, and so on. So for all of these reasons, we recommend that children stay on medication through weekends and summers, rather than coming off, as was the custom back in the 70s through the 1990s now. So there was concern about 2 decades ago that the methylphenidate might be causing chromosomal damage in blood cells. That was never backed up or documented, and indeed inspection of the data showed that the data probably had not been analyzed properly, and there's been no further evidence that these drugs might cause cancer. There was concern that if pregnant women with ADHD took these during the first trimester or two, there might be an increase in birth defects or other problems of the child. There have been 3 population studies now that indicate, 2 of them found no increased risk of physical deformities, particularly in outward appearance, but there is 1 large study that did find a very slight but statistically significant increase in cardiovascular health and in the development of the heart. So some concern there, suggesting that, again, as is recommended anyway, pregnant women with ADHD may need to think about whether they want to stay on the medication or not. That has to be weighed against the adverse effects that can occur of coming off your medication while you're pregnant. And I've already mentioned what some of those risks would be when it comes to injury and so on. There are minor effects on heart rate and blood pressure of virtually no concern in the vast majority of people, unless they already have hypertension as a pre-existing condition, or they have a history of heart defect, heart surgery, or sudden death within their family. Even then, those are simply precautionary recommendations, because there is no evidence in population databases that stimulants increase risk of sudden death. And indeed, compared to the general population, people on stimulants experience less chance of sudden death. And we think that's because they are being monitored for their cardiac functioning, whereas the general population routinely is not. So the risk of death on stimulants was greatly exaggerated in earlier decades and not found to be evident in population-wide studies. There are many misconceptions that people have when they come into our clinics, and we suggest that they consider taking a stimulant. One is there a risk of addiction? This was a big deal made by social critics and one ADHD researcher in her research. This was Nadine Lambert. But all of the evidence subsequently examined shows that this is simply not the case, that addiction to a prescribed medication, stimulant in this case, taken orally, does not occur. You might develop a psychological dependence on it if you're using it at higher than typical doses, and you're using it to function and to stay up later, perhaps as a truck driver, or as Kitty Dukakis did during Michael Dukakis's campaign for the presidency. She became dependent, I believe, on her methylphenidate because of all the campaign stops and scheduling and so on in which she participated, but no risk of addiction that we can see from this. So there was also the concern that the individual might develop a risk later on for addiction to another stimulant, such as cocaine or tobacco. And we now have 19 follow-up studies showing no risk for later substance use or abuse when taking these medications. And indeed, a few studies suggest that if you stay on them through adolescence, the risk of turning to drug use and abuse is less than it would be in unmedicated ADHD individuals who have a higher risk of abusing drugs by virtue of being ADHD. No risk of seizure increase in children with seizures or epilepsy, except at very, very high doses, which of course are not used in clinical practice, but you can use these medicines safely and effectively in people with seizures who have ADHD. The only caveat is there's a slight increase in more side effects and a somewhat lower probability of a positive response. All that being said, the safety is there and they can be used if needed. I've already spoken about using the medicines with people with tics and Tourette syndrome. Used to be thought you couldn't do that, but research went on to show that clinical wisdom was wrong, and that you can safely and effectively use these with tic-prone individuals. There, of course, is concern that we're overusing these medications. Overdosing or overuse implies that there's more drug being given in the community than there are cases of ADHD in the community. And we have not seen that being the case. The number of people within a community on medication is well below the prevalence of the disorder. If anything, when it comes to teens and adults with ADHD, the majority of people who would qualify for the diagnosis remain untreated with medication. But we're doing a better job in the last decade with children, where we have seen a flattening of the medication use, so that over the last decade, since 2011, there has been no increase in the United States in using stimulants with children, especially with boys. There's been a slight increase with girls, but they were underdiagnosed in previous decades. And the major increases continue to be in the segments of the population that were not being properly identified, diagnosed, and treated. And that is teens, and especially adults with ADHD. So the evidence to date suggests that we're improving in our delivery, in our public health management of ADHD with medication. There, of course, is concern that the drugs are being given to the wrong people. That is, typical people are using them for performance enhancement, for getting preferential treatment in college or high school or in their job, for preferential improvement, that is. So some people, especially in college, feign having ADHD in an effort to get a medication prescription. Others may approach a college colleague and ask them to share their medication with them. So that's diversion from a legitimate prescription to someone who is using it illegitimately. And that is a problem on college campuses. Not as big as the media has made it out to be, but certainly something that clinicians need to concern about when they prescribe stimulants to college students living away from home. But otherwise, we are not seeing on a population-wide basis people given medication who don't have ADHD or a marginal case of ADHD. And what do I mean by that? I mean that there are a couple studies that have shown that there are people being treated with medication who are symptomatic and impaired, but might not qualify for all criteria in the DSM. And of course, journalists want to make a big deal of that. If you don't have the disorder, you shouldn't get the medication. But we know as clinicians that ADHD falls along a spectrum, and that ADHD is a disorder that requires medication when suffering and impairment or harm occurs. And it doesn't matter if you do or do not meet all criteria for the DSM. We're not in business for making DSM diagnoses. We're in business to treat and relieve suffering, and diagnosis is a means to that end. But it's not the gatekeeper, and it's not the end itself. So I like to teach journalists and those concerned about these studies that clinicians in these studies are doing what they're supposed to do. Cases of borderline ADHD that suffer and have impairment should be treated, even if they are one symptom short of the requisite 6 or 12 needed for their particular presentation of ADHD. So let's not get neurotic to the point of silliness on requiring that treatment be predicated only on a diagnosis and never at any other time. Now, there was concern that giving stimulants didn't really improve academic knowledge or achievement. There was ample evidence that it improved school productivity, it improved grades, it improved behavior at school, it reduced punishment at school, it improved peer relationships at school. All of those are very well documented. But of course, the short-term studies that lasted typically only weeks to several months on average, we're not able to document an improvement on academic achievement testing, the kind of thing you give children once a year to see how much they've learned in an academic year. But subsequent longitudinal studies, such as by Barkley at Mayo Clinic and others, and my own, included or found that if you took the medication for several years, you did begin to see improvements in academic knowledge and achievement. It just took a while of the person staying on medication and being available for learning for us to detect it on these relatively crude measures of academic achievement. So even that criticism is now arguable and open to interpretation. So the stimulants are very, very safe and effective medications, but they're not meant for everybody. They don't solve all the problems. They may not address comorbid disorders. They have annoying side effects and may not work at all in a small subset of people. But with all of those qualifications, they're pretty good medications, and they are indeed the most effective medications in psychiatry for what they're intended to treat. Now, when we come to the norepinephrine non-stimulant, the norepinephrine reuptake inhibitor, atomoxetine, it of course is unscheduled here in the US, meaning it has no abuse potential or diversion potential. We've had it around for 17 years. There are now millions of cases worldwide who have been treated with this medication, who have a very good evidence base, not only from controlled research, but from clinical practice around the world on the safety and efficacy of this medication for kids, teens, and adults with ADHD. So it's a nice second medication to have for addressing the individuality and idiosyncrasies of our patients. And we'll talk about where atomoxetine might be a preferential drug to use instead of a stimulant shortly. Atomoxetine is equally as effective as methylphenidate in terms of the percentage of people who respond. It's not quite as effective as an amphetamine in terms of the degree of improvement that you get. And indeed, it may not be quite as effective as methylphenidate in that sense, but pretty close. Again, amphetamine is the most potent medication on the market and is more potent than even methylphenidate. So it's no surprise that atomoxetine isn't quite as powerful or as potent in altering symptoms as the amphetamines would be. But then not everybody needs an amphetamine. So about 75% improvement, about a 55% normalization rate matching methylphenidate. Sustained response has been demonstrated in studies that have lasted for up to 3 years and now longer. We see, unlike the stimulants, that the longer you stay on atomoxetine, the better the improvement. So there continues to be improvement after the initial trial on the medication for it at the length of time that you stay on it, which is rather interesting, suggesting there's something going on in the brain, perhaps a resetting of the norepinephrine inhibitor as a result of long-term use of this medication. That's, of course, hypothetical, but something is happening to get this gradual improvement over time that we see in the studies. It's interesting that atomoxetine is a 24/7 drug, which means you can take it once a day or twice a day, and you get the same benefits from the medication. Now, there might be a reason to take it twice a day. So it may be that it produces some sedation, and you don't want that in the morning, but you want it in the evening. So morning and evening might be the time to split dose the medication. But you do get 24-hour symptom coverage. In other words, there are still measurable effects of atomoxetine taken one day on behavior the next day. And that's not true with the stimulant medication. Now, here are the documented effects across the research studies on atomoxetine. I'm not going to read these to you. I wanted you to have them in your handout from my program, but they're very similar. Not identical, but very similar to what we see with the stimulant medications. There's a couple of unique effects here that you wouldn't see with a stimulant. First of all, atomoxetine, being a norepinephrine inhibitor, can be used to treat enuresis. And it does in ADHD kids with enuresis, help improve their number of dry nights. We also see that there is no effect on delayed sleep onset. So insomnia is not a clinically impressive problem with atomoxetine the way it is with methylphenidate or amphetamine. So there is a faster time to sleep onset. As I mentioned, atomoxetine does result in some measurable improvement in morning after behavior, even if the drug isn't given that morning. We also see fewer concerns by parents of emotional blunting or restriction of affect, which is not common to ADHD stimulants, but in my own experience and that of others, about 1 in 5 people taking a stimulant complain about emotional restriction, blunting, an automaton-like appearance to the child. They're just not as emotional. The joie de vivre of childhood it has been limited or lacking. And we don't hear that as a concern with atomoxetine. So another reason one might switch to this drug if that was a clinical issue for a patient. And just as with stimulants, atomoxetine can be used in comorbid cases who lie on the autism spectrum. This chart, which we won't go over, of course, it's just way too busy, but you need it as a handout, shows the percentage of people experiencing the various Strattera side effects relative to placebo from the large studies that were done by the pharmaceutical companies. So I just give you that to take with you as we go. Here's a listing of some of the other side effects. A very, very slight increase in heart rate and blood pressure, nowhere near what you get with a stimulant, but still a slight impact there. Much less effect on growth than with a stimulant, but still mainly an effect on not gaining weight rather than an effect on height, but less dramatic than with a stimulant, and not of clinical concern unless the child is small. There was one report of liver inflammation in 4.5 million treated cases examined at the time. So that could be a very rare concern. I'm sorry, my slides have a mind of their own this afternoon. But again, even this case is arguable. But the earlier concern that there was a liver problem, hepatotoxicity with atomoxetine, has been disproven with the exception of that one possible case. There was a black box warning put on atomoxetine for children, and again extended to the stimulants, suggesting an increase in suicidal ideation. I, for one, found that to be absurd. All of the evidence in the research suggests that if anything, it improves the risks for suicide attempts and ideation, and that is true with stimulants as well. But this black box warning came out of the fact that 5 out of the 1,357 cases in this particular drug company trial, and only at the Boston site, not at the other 20 plus sites, documented an increase in the chart of patient discussions about the medication by parents, possibly being suicidal ideation. You can see the risk here, which is well below the risk of suicidal ideation in untreated ADHD children, which is 6%, and the risk of ideation in teens is 33%, which, as you know, is 100 times greater than the risk found in the trial. So you can see why clinicians like myself belittle this black box warning as having been an overreaction to some of the data that came in from that drug trial. There is a possibility of slow metabolizers with atomoxetine, resulting in them having 2 to 3 times the blood level of the drug. And so sometimes one needs to do genetic testing of the CYP2D6 genotype to see if that is causing overdosing in some children complaining of excessive side effects of that medication. But it's not very common, but it can occur. And of course, the last type of medication I mentioned are the antihypertensive drugs, the alpha-2 agonists, guanfacine XR and clonidine XR. My opinion here is that these are third choice medications because you see here that they're not producing the degree of effect that is improvement in behavior that you would get with a stimulant, which you see over here, or with atomoxetine. But again, about 50 to 65% of people report a reduction in symptoms, even if it's not as striking as with a stimulant. We also find that because of sedation, some people are reporting improved behavior that mainly has to do with this kind of sedative effect of improving impulsivity, lowering hyperactivity because of the sedation produced by the drug. These drugs can be combined with stimulants to get broader coverage of the symptom profile of the individual. Not recommended routinely, of course, but off-label. Clinicians certainly have been doing that in my experience, and the manufacturers have done safety studies showing that they can be safely combined, but not an awful lot of research on that at the moment. Ideally, I think these drugs work well for reducing hyperactivity, oppositionality, explosive or reactive aggressive behavior, but not quite as good at improving school productivity, performance, and working memory and the other executive functions. These drugs, of course, might be useful in the case of pre-existing tics or Tourette syndrome, because not only do they not increase tics, they're actually used as treatment for tic disorders, and certainly no possibility of increasing anxiety with these, as there might be with a stimulant medication. Also, as with atomoxetine, the drug could be given at bedtime to help induce sleep in a child who has pre-existing sleep onset problems or insomnia. Now, here's some of the side effects seen with guanfacine, and to a little bit more commonly with clonidine. Again, the principal side effect, as you see up here, is sleepiness of the individual, particularly during the first few weeks of titration of the medication, but also a not insignificant number complaining about headache and, to a lesser extent, abdominal pain. And then, of course, far fewer people complaining of these side effects from the alpha-2 drugs. The side effects do decrease over time, but can last longer than that. And if necessary, monitoring blood levels of guanfacine, particularly if it is being combined with the anticonvulsant of valproic acid, valproate. And of course, a recommendation not to combine this drug with Abilify. So those are your medications. Those are the drug classes. Those are our behavioral effects and side effects. Overall, I think a pretty good risk-benefit ratio for these medications compared to other psychiatric drugs. Now, there has been a big push over the past 5 years to identify ADHD children earlier and to intervene with them earlier, as I discussed last week as well for ADHD. And these 7 reasons are, of course, reduction in symptoms and improvement in executive functioning, and doing that as early as we can, improving family stress and parent-child conflict, reducing impairments in the individual's life, thus improving their quality of life, improving health-related issues, particularly the risk for accidental injury, early mortality, possibly suicide attempts in adolescence and young adulthood, perhaps lowering the risk for future comorbidity, as with oppositional disorder discussed in the last presentation, lowering the burden of care to the family and to society by treating earlier, and then, of course, the possibility of accelerated brain growth in longer-term stimulant medication usage. We know that the brain in ADHD is delayed in development, as seen here in Philip Shaw's large developmental neuroimaging study of gray matter maturation. And we see here where the lag is occurring in the development of the cortex, mainly in the frontal lobe, as I discussed last week. And studies now, beginning with the Ivanov study on cerebellar morphology, have compared people, youth on stimulants to youth who didn't take stimulants, and showing that there is increased brain volume in the stimulant-treated individuals. And here's a picture of that study. Here are the abnormalities in the cerebellum associated with the diagnosis of ADHD compared to healthy controls. These are highly reliable findings. The cerebellum, even more than the cortex, has been shown to be problematic in its development in ADHD individuals. So it's not just cortical development. And this shows that many of these areas, you can see it here on cross-section, that were found to be abnormal are correlated with degree of symptom severity in ADHD patients. So this isn't simply illusory correlation here. The cerebellum is related to symptom severity of the disorder. And then here you see where the cerebellum is growing or larger in stimulant-treated versus untreated cases of ADHD. And again, this isn't a randomized controlled trial. We can't do that trial. You can't keep people on a placebo for 2, 3, or 4 years while you study the active medication and whether or not it's resulting in brain growth. No institutional review board, no ethics committee would allow such a study because of the harm that is posed to the placebo group of not having their ADHD properly treated for a sustained period of time. So when critics say, oh, we need to do controlled research of long-term effects, both behavioral effects and these neuroanatomical effects, well, folks, we can't do those studies. So it's a lame criticism. We have to infer from these kinds of longitudinal studies and other scientific designs that there is an effect here. But of course, we have to concede that this is not the definitive evidence one would get from a randomized trial that lasted several years, but you're never going to see that study. We had Sobel's research done looking at the basal ganglia in the central part of the brain. Here are the 3 major nuclei in the basal ganglia, the caudate, the putamen, and the globus pallidus. And what you're seeing here, the blue area is the area that is disturbed, that is not developing. It is abnormal when we compare ADHD individuals to healthy individuals. Again, these findings are quite reliable across neuroimaging studies, showing that the basal ganglia is a major neuroanatomical site for producing ADHD. And here we see the changes that were rendered both to the inside of the basal ganglia and the outside surfaces of the basal ganglia. These are ADHD patients not taking stimulants, and we see major abnormalities in their basal ganglia nuclei. And here are the patients taking stimulants for several years. And the green area indicates no differences from the control group or insignificant differences, and the yellow areas indicating where there may well be improvement. And here, again, this is the inside of these nuclei, and this is the outside surface. So it's not just the cerebellum, it's not just the basal ganglia, it also includes studies looking at the cortex as well. And here is a review of Tim Willens and Tom Spencer of 29 studies that found this therapeutic benefit. More recently, it has been found in adults with ADHD, and also in studies looking at neuropsychological measures. Now, some people ask me, well, what about the non-stimulants? Do they do this? Well, we don't know. All of the research I've mentioned was done with stimulant medications. We also don't know how long you have to stay on the medication to get this benefit, several years, apparently. We don't know whether you get more benefit from one stimulant or another, or from one dose over another, or what characteristics of the patient might predict this. Those are all questions that remain to be answered. But we have a growing body of evidence here that arguably suggests that at least a significant minority of patients, in the studies I looked at, about 25 to 40%, showing such improved regional volumes or growth. Will this extend to atomoxetine? We don't know. But about 70% of the brain areas that are activated by atomoxetine are also activated by methylphenidate. And you'll see this is from the Schultz study, showing that both drugs act on the left and right primary motor cortex. And yet there are also regional differences between atomoxetine. We see here that atomoxetine is mainly working in the prefrontal and medial anterior cingulate areas, while the stimulants may also be working in the anterior cingulate as well as down in the basal ganglia and also in the nucleus accumbens and so on, because of course that's where it's producing its addiction potential. So there are differences in the areas activated by the drugs, not just similarities. So we don't know whether atomoxetine would do this or not. It's certainly possible that it might. I don't want to dwell on this slide because this is an accredited presentation, and I'm certainly not recommending off-label use of medications. But if a clinician were to ask me what medications are people using off-label, this would be the list of things that are being tried in research studies or by some clinicians. And I'll just leave you with that list. It's possible in the future that we may see new drugs being developed for ADHD, some being based on increasing knowledge of the neurochemistry of the executive brain, the prefrontal cortex, and how it influences its top-down control. We know, for instance, this is principally where the alpha-2 agonists are having their effect on ADHD rather than on deeper structures in the brain like the stimulants do. Maybe we'll find other drugs that could fine-tune the executive brain, not sure. We're also seeing some drugs being tested for dopamine type 1, not just type 2 and 4. There's evidence from genetic studies that GABA is a chemical in the brain, glutamate that is, that might be involved in ADHD, and therefore glutamate enhancing medications might benefit people with ADHD. So there are some companies and researchers like Amy Arnston that are investigating that. Companies have looked at the nicotinic receptor molecules because there's evidence that nicotine improves ADHD symptoms. So far, these have not been very successful trials, but there may well be a way of developing a nicotinic receptor for ADHD. So I think it will be in the area of ADHD genetics where we get our guidance as to where to look in the brain and what new chemicals might be helpful in managing ADHD symptoms. I want to conclude with a quick review of factors that clinicians should think about in choosing which type of medication they might want to start with or switch to in the management of someone with ADHD. Unfortunately, most people don't talk about this. They just throw the drug out there and see what sticks. But we know from reviewing these hundreds of studies that there are these characteristics that we might want to think about. So I'm going to split them into three domains. One are issues related to the context that the patient is in. Is the patient in such a situation where we need to get urgent control right now? The patient's in crisis. They're in an environment or a situation where it is urgent that this child be managed or this adult be managed immediately. Well, folks, there's no more rapid drug than a stimulant at getting control. You don't need to wait weeks to judge a stimulant dose. You know within hours of giving that dose, if it works, you literally could be titrating that drug, especially if you're using the immediate release drug, dose by dose, or every day adjusting your medication. We like to wait in adjustment just to look at the effects in all the various situations in which the patient has to perform. But if it's urgent, you could titrate this dose in several days and not the several weeks it takes for the non-stimulant medication. So no question, where urgency is at a premium, one would choose a stimulant. What about the duration of action? Luckily, because of delayed or because of extended release forms of the stimulants, that's less of an issue than it used to be previously. But even there, atomoxetine and the alpha-2 drugs last longer than do the stimulant medications. So if that's an issue and we need coverage 24/7 or maybe helping with sleep onset, a non-stimulant might be your choice. What about consumer acceptability? The media has done a real hatchet job on the stimulants such that patients come into us already primed to say no to Ritalin. And they're less primed by the media and its horrific stories that are not true of sensationalizing these drugs. They're less primed to refuse to use a non-stimulant because those are, of course, safe and there's a lot fewer negative articles about them. So sometimes it's just hard to get patients to think about a stimulant where they might find a non-stimulant more acceptable, even if we educate them about the safety of stimulants. Of course, can the parent or the patient supervise the use of the medication? You're sending a Schedule II, potentially addictive or divertible drug out into that context. It needs to be monitored properly and make sure that if it's being used, it's put away and that people can't get at the medication. So it's guarded, or in the case of the patch, it's being disposed of properly. So you're not leaving a Daytrana patch in a wastebasket for a 2-year-old with pica to suck on and get the remaining medication that exists in the patch. So, all of this has to be thought about in terms of not just the delivery system, but the medication type itself. Is there a history of adverse reactions to that stimulant among other family members? If there is, well, that could signal that this patient might well share that same adverse reaction to that drug. Is there a drug abuser living in the household? If there is this person going to steal the prescription medication being given to the other family member and then either sell it or abuse it themselves? So you need to think about family context, control, supervision, the other people who are living with the treated patient. Is that going to pose a problem? I've mentioned already the high risk of diversion, or at least the elevated risk of diversion on college campuses or private high schools where the ADHD student is living away from home, has a scheduled medication and is using it, and their roommates know about that and may asked to use the medication as well. This may be an instance where if the patient is running out of their medication sooner than they would and are asking for refills faster than would be the case if they were taking it as prescribed, this might signal diversion and might suggest a switch to a non-abusable or undivertible type of non-stimulant medication. There is, of course, the issue of availability. Some of these, particularly the patented medications, may not be available, particularly to poorer clients here in the US who have to go through the Medicaid system in order to get their medication, and those state systems rarely approve the expense needed to obtain the types of delivery systems that are still under patent, and as a result are much more expensive to get. So not all delivery systems are available everywhere or are affordable everywhere. So we may need to look at generic atomoxetine or generic forms of the stimulant delivery systems for those patients. So context is important. Now also there are characteristics of the individual patient you might want to think about. One, of course, is what other drugs is the patient taking that are contraindicated for giving a stimulant to them. We talked about not just stimulants, but also the alpha-2 agonists and Abilify for them. If a patient is already on a stimulant, you wouldn't be giving another stimulant for another reason. So we need to be careful about that. It's not as big a problem as it might be for other psychiatric drugs, but still it should be in the back of your mind to consider. Patient age, as I've mentioned, young patients don't do as well on stimulants as people 5 years of age and older do. So that might be an age where atomoxetine might be used because we haven't seen as much of an age-related effect with atomoxetine, in my opinion, as we have with the with the stimulants. Not to say you can't use a stimulant with a preschooler, but that you might think twice about that. Etiology, it looks like acquired cases of ADHD, at least suggestively to me in the literature, don't do as well on stimulant medication. Now, we don't know about the non-stimulants, but in looking at stimulant medication, we do know that if patients acquire their ADHD through head trauma, penetrating head wound, fetal alcohol syndrome, or exposure, or let's say low intellectual ability of an IQ of 50 or lower, which suggests that there's been an acquired injury prenatally or postnatally driving that ADHD case, well, we know that those instances that I've just mentioned don't do as well on medication, having less than a 50% likelihood of responding compared to individuals who have the more familial, genetic, or idiopathic type of developmental onset of their disorder. All of that would suggest that you're not going to get quite as good a drug response where there's a clear event that led to the cause of the ADHD, an acquired form of ADHD. So don't expect that the drugs will do as well, and particularly the stimulants, with those cases. There's a small body of evidence suggesting that girls with ADHD have a different peak to their drug response to a stimulant, this case methylphenidate, than do males. And you can see it here. The effect might be earlier in the day rather than later in the day. So that could be something to think about. Certainly the kind of attention disorder that I mentioned last week when we talked about SCT does not do well on stimulant medication. Doesn't make them worse. They just don't seem to respond very well to it. About 20% responded in my study. The more SCT symptoms you have, the more or the less likely you will see a positive response to a stimulant. So that's something to consider. Finally, there is comorbidity, which I'll go back into in more detail next week, but which I've also sort of highlighted a little bit in my earlier presentation. And that is that there are various disorders that would suggest one think twice about using a type of medication with them. For instance, stimulants in very small children, that might be a case where a non-stimulant would be used, or drug holidays would have to be instituted to address the problems of growth retardation in stimulant-treated children. If a child already has bedtime problems like insomnia, 40% of ADHD children have pre-existing sleep problems without going on a stimulant. And it may be that those are the cases where we might not want to try a stimulant and try a non-stimulant first, because it won't worsen that problem. Anxiety, arguably, is a predictor of stimulant response. Some studies find that people who are anxious and have ADHD do just fine on stimulants, and it's not a problem. But just as many studies show that stimulants have the potential to exacerbate anxiety and worsen, by the way, working memory in anxious cases. Here again, one might think stimulant or non-stimulant. Non-stimulants don't worsen anxiety. Strattera, atomoxetine, actually treats anxiety. So again, something to think about when we have these comorbid internalizing disorders. I've discussed the tic disorders and the tic reactions. About a third of tickers have a worsening of their symptoms on stimulants, especially amphetamine, much more than methylphenidate. Here again, non-stimulants might be the drug of choice there, but again, you can use a stimulant for about 2/3 of those cases. And we find that there's research in Canada, over in Montreal, suggesting that methylphenidate, you get about half the degree of response if an ADHD child has a math disorder. We don't know why, but this has been now documented in several studies, that the presence of a comorbid math disorder reduces stimulant response by 50%. So again, something to think about in choosing medications. So overall, the medications for ADHD are among the most effective treatments we have for any psychiatric disorder, quite effective for managing most cases of ADHD, but not all. There are at least 3 classes of medications. They differ in the way they impact the brain and the way they change behavior. And that needs to be thought about in choosing medication. We find that the vast majority of people respond, and over half of them may well be normalized by the medication, and that the degree of improvement is far greater than we get with other psychiatric medications. So overall, a very good window of safety and tolerability with these medications. The greatest problems, at least here in the US, we find are, number one, acceptability. The media has done a really good job of convincing people that these are harmful medications that shouldn't be used. And so it requires more effort by clinicians to convince patients to try them, even though the media are wrong about this, as they are wrong about a lot of things that they choose to sensationalize. Availability, as I've already mentioned, is problematic here in the US. Not all delivery systems are everywhere and are affordable everywhere. But the biggest problem is that of non-adherence. Patients stopping the medication within 3 months to 3 years, but usually 3 to 6 months for children. So that the average patient is on the medication only about 2 to 3 years and then comes off. Now, adults stay on the medication longer than children do. And one of the problems, of course, is side effects. People don't like the side effects and don't think the medication is worth it. The second problem is cost. Patients say, well, there's improvement, but we can't afford these medications here in the US anyway, so they stop taking. The third problem is the child grows up and begins to individuate from the parents, and the child is not amenable to taking the medication. After all, the child didn't call you for the appointment. They don't think they have a disorder. And so it's no surprise that out of all the people given stimulants in childhood, only 25% of them are still on medication in high school. And that may have to do with the fact that the patient, in this case, is not the person who wanted the medicine, wanted help, and wants treatment. Indeed, in my own longitudinal study, only 5% of children growing up with ADHD at age 21 thought they had a disorder, ever. So it's going to be until they get into their 30s where they finally wake up and smell the coffee and realize that they do have a problem that does require management. So sometimes the problem with non-adherence is the denial or lack of awareness of disorder in the child who is growing up with ADHD. So that said, I'll conclude my presentation and I'll turn it over